So welcome everybody. My name is Dr. Andrew Gomez. I'm a sports medicine physician. And today we're going to talk about shoulder impingement. I'm really grateful to IRG for inviting me to talk. So the contents of the talk, there's going to be 7 components to the talk. We're going to talk about who I am and who I practice with. We're going to talk about shoulder anatomy. We're going to talk about the presentation and pathophysiology of shoulder impingement. We're going to talk about how to evaluate shoulder impingement, non-operative treatments, orthobiologic interventions, and a bit about my practice. So, lots of text. My primary goal today is to educate. I'm curious, in the room, because we have a pretty small audience, I know we have 2 physical therapists, Sophie, who's with marketing at IRG. Do you mind if I ask the background of the other folks in the room, just out of curiosity?
You know, I'm reticent to say this, but I've had shoulder issues, and I had this procedure by Dr. Andrew Lloyd last Thursday through Swedish.
Oh, Dr. Lloyd, one of my former colleagues.
So I'm here to learn a little bit more about what he did to me last week.
Awesome. Did he see you at Cherry Hill or
Cherry
Bellevue?
Hill.
And then your daughter?
Yes. It's actually my grandmother.
Oh.
I'm still in the nest.
And what about you back there? Any background in sports medicine or rehabilitation?
Mostly athletic into it, and then I had the knee injury that I recovered myself because I was obsessed with health and anatomy in general. So.
Very good, very good. Well, welcome to you all. I want to educate you all. I want to give you a bit of information about shoulder impingement. And the reason I like to know about the audience is I can kind of titrate the information in the talk accordingly. So now that we know that someone has had PRP in their shoulder, we can dig into that a bit further. We're going to talk about orthobiologics generally, and specifically, we're going to talk most about PRP. We'll talk about my practice, as I mentioned before, and we're going to talk about Pixel and how maybe myself and folks in this room could collaborate. I'm from a small town. I like math. I did medical college at Columbia University. My first job was a math tutor at Eastern Arizona College when I was in high school. So that's a bit about me. Kind of boring stuff. Dr. Porcho. So I'm going to start practicing with Dr. Porcho. Has anyone heard the name Dr. Porcho by any chance? So Dr. Porcho, he was faculty at Swedish. He trained me. He's about 5 years into his career above or ahead of me. He's from Detroit. He does a lot of cutting-edge orthobiologic treatments. We'll dig into it a bit further. Anatomy. So, is it possible, Sophie, to dim the lights a bit? So, there's 2 joints in the shoulder, and the major joint of the shoulder that most people think about, it's called the glenohumeral joint. Now, the big pink arrow, that denotes the glenohumeral joint. We talk about it as a ball and socket joint. The truth of the matter is that it's not really a ball and socket joint. The socket, or the glenoid, is relatively shallow and flat. Now, that's pertinent because there can be translation of the humeral head a little bit. So when a patient has a bit of shoulder instability, and there's a bit of that translational component to that glenohumeral joint, that can give rise to impingement. We'll talk about it further. Now, in the shoulder joint, the glenohumeral joint specifically, there's 2 types of cartilage. When we think about cartilage, most of us think about hyaline or articular cartilage. And that's the cartilage that's really good under compressive force. It's what wears out in the setting of osteoarthritis. But there's another type of cartilage inside of the shoulder joint as well. It's called fibrocartilage. It's the same material that your ear's made out of, so it's got shock absorptive properties. It lines the periphery of the glenoid, and it's called the labrum. Besides the physical therapist, anyone heard about the labrum before? Okay, so it's analogous to the labrum in the hip, it's analogous to the meniscus in the knee, and given that the glenohumeral joint is not necessarily a ball and socket joint, how is it stabilized? Well, obviously there's a lot of ligamentous tissue, the joint capsule, that holds things in place, and then we have the very powerful deltoid muscle that sits on top of all of this anatomy. But the rotator cuff is one of the primary dynamic stabilizers of the shoulder joint. We're going to talk a bit further. Now, the small joint on top that's circled by that pink, that has the pink circle around it, that's the acromioclavicular joint, or the AC joint. Now, getting into pathologies about the AC joint, it's a bit outside of the scope of this talk, but when the AC joint has problems, it can have implications for the rotator cuff. We'll talk further about that. So, next, the rotator cuff. So the rotator cuff, a lot of people have heard of the rotator cuff, but not many know about the anatomy specifics. So the rotator cuff, it's 4 muscles, it's 4 tendons. Those muscles originate from the scapula and they connect to the head of the humerus. So this is looking at the front, this is looking at the back, and you can see that the rotator cuff connects essentially all the way around the head of the humerus, with the exception of the undersurface of the humeral head. Now, in terms of the other structures that you'll see on this image, I put a little oval here because that's a key location when we talk about impingement. That's the subacromial space. Now, let's get back into the rotator cuff. Any questions about the function of the rotator cuff before I continue? Is it evident that it's a dynamic stabilizer of the ball and socket joint? So let's dig into that a little bit. Again, the glenoid is relatively shallow and flat. Unlike the hip joint, for example, the hip joint, the socket of the hip joint has a pretty decent amount of purchase on the head of the femur. That's in contrast to the glenohumeral joint, where again, the head of the humerus can translate just a little bit in most of our shoulders. Now, the problem with impingement is when, we'll dig into this further, but if there's a little bit of that micro instability, it can give rise to issues in this subacromial space. Now, let's talk a bit further about subacromial impingement. So, what are we looking at here? We've got MRI images. We've got another illustration of the rotator cuff and the bursa. Basically, when there's that a bit of micro instability of the shoulder or repetitive upward translation of the humeral head, it's hard to show here, but here's that acromion. So the acromion is here. The acromion connects to the clavicle or the collarbone. There's the AC joint. Now, here's the acromion, and this is taking a slice like this, so what we call a coronal section. This is a sagittal section, cutting like this. Now, you can tell, here's the head of the humerus, here's the acromion, so acromion, head of the humerus. If the head of the humerus translates upwards a bit, it's going to pinch the tissue in that subacromial outlet. Does that make sense? Now, that is the essence of what external or subacromial impingement are. The physical therapist in the room will talk about other types of impingement, internal impingement, but for the sake of this talk, we're going to talk about the routine external subacromial impingement. Now, typically, the structures that are involved with impingement, it's the rotator cuff muscle and tendon that connects to the top of the humerus. Why is that the case? It's because it's the tendon that, or the muscle and tendon that's in closest proximity to both of those bony structures. So when we looked at the rotator cuff anatomy, we saw that there are tendons that connect to the front and the back of the rotator cuff, but the acromion is a bit out of the way from those rotator cuff muscles and tendons in the front and in the back. Whereas the muscle and tendon that connects to the top of the head of the humerus, that's the one that can get pinched in between the acromion and the upper surface of the head of the humerus. Now, I think it's interesting to note the long head biceps tendon, it is denoted in this image, and it actually has a role in being protective in this role of impingement. We talked about the glenoid, we talked about the socket. The long head biceps tendon connects to the top of the glenoid. So it actually pushes the head of the humerus down and is a bit protective in regard to this process of impingement. Now, what are the symptoms? The symptoms, they're variable. Typically, patients will report pain in the deltoid region. Symptoms can radiate down to the elbow. Symptoms are often aggravated with laying on the affected shoulder, overhead activities, repetitive overuse. So it is, those are usually the classic symptoms, but in some cases, patients will show up and they'll say, my shoulder hurts right here, right in front, or in the back. So in terms of the location, usually it's that deltoid region. It can radiate to the elbow. Usually the symptoms are not described as neuropathic. Usually we're not going to hear about numbness, tingling, or burning. If we do, it often raises suspicion that radicular symptoms or neuropathic symptoms from the neck or elsewhere are present. So usually it's pretty classic symptoms, achiness, it can be sharp, but usually not electrical. Now, the symptom varies. I've seen some patients be absolutely miserable with this process, whereas some patients, they're a bit apathetic about their discomforts. So, anatomic considerations. The acromion. The acromion, it has a number of different morphologies or shapes. So we talk about, if I were to get an MRI on a patient, it's not uncommon when I take a look at the MRI report that the radiologist will call out whether or not the patient has a type 2 or type 3 acromion. Now you can imagine, type 1 is relatively flat, type 2 is curved, type 3 has a little hook at the end. And just for reference, in the 3 images here, we're looking at the shoulder from this perspective. So we're looking directly at the glenoid. You could imagine with a type 3 with that little hook, that little subacromial space may be a bit more diminished and be at increased risk for impingement. So that's one anatomic risk factor. The other anatomic risk factor that some radiologists will call out, some won't, is a downward. So on the right, the bottom right image, you see a relatively flat acromion. And then on the other side, you see a downward sloping acromion. It stands to reason mechanically that a downward sloping acromion does put a patient or an athlete at risk of impingement a bit more than a flat acromion. Weakness and deconditioning of the rotator cuff. We see this very, very frequently. So you could imagine if you have muscle and tendon tissue that is a bit deconditioned, a bit atrophic, a bit weak, it's not going to do its job as well as the rotator cuff that is limber and flexible and conditioned. So rotator cuff weakness, a little bit of atrophy certainly can contribute to altered dynamics of the ball and socket joint. So that certainly can give rise to impingement. Ergonomics. I think it's important to note ergonomics. What we see a lot of patients doing weighted overhead activities. We see a lot of patients who are laborers, blue-collar workers who have to do overhead work, painters, electricians. We see white-collar folks who do programming work and they lean on their elbows quite frequently. And when we lean on our elbows, that force will be transmitted upwards and potentially put pressure on that rotator cuff tendon, the supraspinatus. I'm not sure if that makes sense. I wanted to bring a 3D model to make this make sense. Unfortunately, I don't have one, but any questions about how leaning on one's elbow could transmit that force upwards and pinch the rotator cuff? Does that make sense? Cool. Now, what's the natural history and what do we often find in impingement when we're looking? And the physical therapist may catch a little nuance here. We'll see if they do in that image. That's supposed to show rotator cuff arthropathy. There's a little nuance there that's not quite the way I want it, but early findings with impingement. Let's actually delineate things a bit further here because I think it's important to know how clinicians make the diagnosis in clinic. There's clinical diagnoses. We can make a clinical diagnosis based on a history, based on a physical. A classic example is frozen shoulder. A patient shows up, their shoulder hurts, they have diminished range of motion, actively, passively. I don't really need imaging to say that this patient has a frozen shoulder. That's a clinical definition, so that's a clinical diagnosis. Now, shoulder impingement is a clinical diagnosis. So if a patient has a certain set of symptoms, they have certain physical exam findings, usually it's enough to say, hey, this is impingement. That doesn't tell us to what degree the soft tissue may be upset, injured, or inflamed. So what I mean by that is there's a spectrum of disease or findings on imaging that could still all be related to this mechanical process of impingement. Now, early on, if the rotator cuff is a little bit upset, sometimes imaging looks totally normal. Early findings, sometimes we'll find a little bit of fluid in the bursa, what we call bursitis. The later stages, in the third bullet point there, rotator cuff arthropathy. So rotator cuff arthropathy is when the patient has been impinging for so long that they basically attritionally chew through the rotator cuff. So you can have full thickness attritional tears of the rotator cuff related to long-standing impingement. So the point here is that there's a spectrum of disease. Now, the topic of fluid in the bursa, most of, I'm sure, folks in this room have heard the term bursitis. What the heck does it mean? I find myself explaining this to patients quite frequently, so I think it's important to kind of throw this out there. So when we see fluid in the bursa, it doesn't mean that the fluid is causing the patient's pain. The fluid in the bursa, the questions I get are, how do I get rid of the fluid in the bursa? And is that the source of my pain? I educate patients in the following way. Let's use an analogy, if I were to get struck in the arm hard enough such that there's a bruise, there's going to be swelling or edema. That edema is part of the inflammatory process. So inflammation, what are the signs and symptoms? Warmth, redness, swelling, dysfunction, classic inflammation. Now, in the example of getting struck, a superficial contusion, that fluid or edema is going to track in the subcutaneous layer. So it's going to track in this layer of my tissue if I were to get struck there. Now, in the deeper layers of the musculoskeletal system, if a tendon, a ligament, a structure is inflamed, where do we detect that fluid or edema? In the nearby reservoirs, the bursas. Now, let me just pull up the picture 2 slides prior. The bursa that we see fluid in early on is the subacromial bursa, sometimes referred to as the subacromial subdeltoid bursa. Now, the deltoid muscle, I want to just make reference to one anatomic structure I didn't really define early on, the deltoid muscle, the very powerful muscle that sits on top of this anatomy. That's one of the primary movers of the shoulder. Now, certainly the pec muscles and the periscapular muscles contribute, but it's the deltoid muscle that is one of the primary movers of the humerus and the shoulder. The bursa, the subacromial bursa, it's normally should be two-dimensional. Normally, we shouldn't really see it on imaging. It's the plane where these two tissue structures glide over one another. So when we look dynamically with ultrasound, we can see these two layers shearing at that bursal interface. So let's move on. What do we find on the history? And what do we find on the physical? I find that for your garden variety impingement case, all I really need is a history and a physical. We can clarify details with imaging. We'll talk about that in a moment. The history and physical, even though I'm a very tech-forward person, we're going to talk about that, it's hard to replace. The history and the physical are really, really crucial in sorting out impingement and a lot of musculoskeletal issues. I'm sure the physical therapist would agree. What do we see in impingement? Sometimes we see diminished range of motion. Sometimes range of motion is normal. It really depends upon the how severe the downstream consequences are. Sometimes we'll see strength deficits. If we see a significant strength deficit and if we have the right history, obviously we may be concerned about a rotator cuff tear. Now, the weakness, if there is a bit of weakness, and let's say that the deltoid's intact, the rotator cuff is intact, often relates to this idea of pain inhibition. Pain inhibition, it's a bit tricky to wrap one's head around, but when a musculoskeletal structure, a muscle or tendon is upset or injured, inflamed, we often unconsciously don't load it normally. We protect it, and it manifests as weakness on the clinical exam. It's pretty common. So we can see variability in range of motion, variability in strength testing, and then impingement signs. So impingement signs, very well described in the medical literature. So if any of you have a shoulder problem, you go to a sports doc or a physical therapist, they're going to do some special tests to maneuver the shoulder to try to figure out what's going on. Hawkins-Kennedy is one of the classic impingement tests. Jobe or empty can test, another classic. And then Neer's test. Those are 3 impingement tests. If a patient has 2 or 3 positives, it's usually safe to say, hey, I'm worried about impingement. Let's take a look with imaging. Now, The two simple, cheap, and easy imaging modalities are X-rays or radiographs and ultrasound. I hear very frequently in my practice, why do we need to get an X-ray? It's only going to show the bones and the joints. I'm pretty sure this is a soft tissue injury. Most of the time, the patients are right. I'm just going to take a drink really quickly. However, the bony anatomy, as we talked about earlier, the acromion morphology, really matters because it can inform the prognosis for a patient. Furthermore, if we have a patient who's, let's say, 52, an electrician, and they have impingement, it's obvious on clinical exam, any underlying arthritis of the glenohumeral joint or the acromioclavicular joint can also impact the prognosis. And what I mean by that, in musculoskeletal medicine, and I'm sure that the physical therapists have found this as well, it's common that there's a primary pain generator and then secondary contributing factors. So if I get an X-ray and I see that a patient has moderate glenohumeral joint arthritis and mild acromioclavicular joint arthritis, those are variables that can impact their prognosis and certainly their treatment plan. Even if we were to adequately, perfectly treat the shoulder impingement symptoms, if a patient has underlying arthrosis or arthritis of the glenohumeral joint, there may be underlying pain that may not be related to the impingement process, and that can kind of confound the picture a bit. Now, the other thing is if there is arthritis of that acromioclavicular joint, the acromioclavicular joint, if arthritis is present and there's some of the classic what we call hypertrophic changes or spurs around the periphery of that joint, the undersurface or the inferior side of the acromioclavicular joint, if there are pretty significant spurs, that can have bearing on the mechanical friction between the undersurface bony structures and the upper surface of the rotator cuff. A little bit tricky to understand, but basically, let's point out the acromioclavicular joint. So if this joint is really, really arthritic and there's these spurs that are oriented downward, it can certainly impact the rotator cuff. So the X-rays matter. That's the point. Now, again, because impingement is a clinical diagnosis that really primarily describes the mechanical process of what's going on, it doesn't tell us about the integrity of the tissue. So with ultrasound, I can see the entire rotator cuff. And I'm sure when you visited with Dr. Lloyd, he probably did his really fancy diagnostic ultrasound. I do that as well. I think Dr. Lloyd was also trained by Dr. Porcho, I'm not sure. But Dr. Porcho, he's really kind of an expert with this stuff. What can I see with ultrasound? I can see, first and foremost, is the rotator cuff intact? Most patients, when they show up with a shoulder problem, they're worried, hey, did I tear something? Does something require surgery? We can rule that out or rule that in really, really easily. We can determine whether or not tendinitis or tendinosis is present. We can certainly see whether or not there's fluid in the bursa. And although X-rays are more sensitive and a bit better at determining whether or not arthritis is present, we can even make the determination whether or not arthritis is present in the glenohumeral and acromioclavicular joint. Essentially, we can get all of the imaging data that we need to make clinical decisions with X-rays and ultrasound alone. There's one exception to that. Let's get into MRI. The only structure that I can't adequately visualize with ultrasound and X-ray is the labrum. The labrum, again, it's fibrocartilaginous, the same material that your ear is made out of. It lines the glenoid. So the function of the labrum, it's understood to increase the contact surface area between the glenoid and the head of the humerus. So it's the structure that kind of lines the glenoid, increases that contact surface area. It's got nerve endings, so it does provide a bit of feedback about the health of the shoulder to a patient. Now, I can't adequately visualize a labral tear with my ultrasound or X-ray. In that scenario, usually what we're going to do is we're going to order an MRI arthrogram. What that means is it's a routine MRI, but the radiologist or the radiologist PA, they're going to inject a little bit of contrast inside of the shoulder joint, and that contrast shows up as that bright white signal on the image in the top right. The pink arrow delineates a labral tear. It's pretty subtle, but it's there. I think because one of my primary goals is to educate with this talk, I want to talk about the utility and some of the issues with MRI ordering. I think it's really important to get into this a bit. The reason being is we'll see a ton of patients, they'll show up first visit and they'll politely or maybe not so politely request an MRI. Totally fine. I would want the same thing. The issue is whether or not the MRI is going to be paid for by insurance. So it gets into this idea of medical necessity. So I will tell you that from the insurance company's perspective, I don't share this perspective myself. From the insurance company's perspective, usually the MRI, it's used for pre-surgical planning, meaning if a patient doesn't need surgery, the insurance company will unlikely pay for the MRI just for the reassurance of the patient. That's just the way it is. Now, certainly if a patient is evaluated and they have their x-rays and their ultrasound, they do their physical therapy for 6 weeks, the conservative care for 6 weeks, and the symptoms persist, the insurance companies across the board will pay for the MRI. Now, I want to suss that out a little bit further. If a patient shows up and they tell me, hey, my shoulder's been hurting for 3 to 4 weeks, and then let's say we do a physical, they've got normal range of motion, they've got normal strength, they're probably not going to go see a surgeon in the short term. They probably don't need surgery because surgery is really a mechanical fix to a mechanical problem in the realm of orthopedic surgery. A ruptured tendon, a ruptured ligament, a broken bone, that's where orthopedic surgery shines. Certainly there's a lot of other cool things that orthopedic surgeons do. But most of my surgeon friends would be very apprehensive to want to make an incision and modify the anatomy for a patient who has normal range of motion and normal strength. That's just kind of what I've gathered, and that's usually the case. Usually patients are reassured to hear that, but the MRIs, I just want to emphasize, typically for pre-surgical planning, I don't really need to see MRIs that frequently, given that I have the benefit of using X-ray and ultrasound, but I order them all the time. I order them all the time primarily because patients do want to see them, which I totally respect that, because if I were a layperson, I know that there would be some degree of increased trust with getting the gold standard imaging, and certainly MRI is the gold standard imaging. Any questions about imaging from anybody? Cool. How do we treat shoulder impingement? The acronym that is kind of old school is RICE, rest, ice, compression, elevation. Newer school, PRICE, protection, rest, ice, compression, elevation. New school, protection, optimal loading, ice, compression, elevation, from Bruckner and Kahn. It's a sports medicine textbook. So this is kind of what a lot of sports medicine docs will talk about: protection, optimal loading, ice, compression, elevation. What is optimal loading? Why does that matter? Rest does have some degree of risk associated with it. Rest, our muscles atrophy and get weak very quickly, quicker than most people think. That weakness, that muscle atrophy can have bearing on the patient's trajectory. What is optimal loading? That's why we have our physical therapists. So sometimes a patient, if they have really diminished range of motion, maybe they're going to start out with gentle isometrics. Whereas a patient who maybe has great range of motion, great strength, but let's say rotator cuff impingement, they may be at the point where they're already doing weighted activities with bands, so isotonics. Is that isotonics? Yeah. So optimal loading is key. I often get the question, ice versus heat, which one should I pick? Really what informs my perspective on that topic is the risk involved. And what I mean by that is ice and heat are both very, very low risk. So I tell patients, because it's low risk, experiment with both, stick with what works, get rid of what doesn't. There's a bit of nuance there. So ice I want to use an analogy, a rubber band. If you put a rubber band in a fridge and then you pull it out, it's a bit more taut, it's not as limber or mobile, or I'm not sure, there's a lot of terms I guess you could describe, and it may be at risk of tearing if I stretch it too much because it's cold. Now, heat, on the other hand, you get a rubber band, warm it up, it's going to be a bit more, it's going to be less rigid. It's going to be a bit more elastic, I guess. The same is true with biological tissue. When it's cold, you don't want to ice your ankle or your hip or your shoulder and then get into physical activity. That's usually not what's advised. Usually we want to ice after activities because of that analogy. And that's expert level evidence, but usually that's unanimously recommended across the board. Heat, because heat can mobilize tissue, increase perfusion, we often heat before activities. Now, a little bit more nuance, ice does have mild anti-inflammatory properties. So if there's inflammation, ice can certainly help. Heat can potentially increase perfusion, and if there's a really severe inflammatory response, it could ramp that inflammatory process up a bit. So those are some of the guardrails in terms of using ice versus heat. Physical therapy. I recommend a ton of my patients do physical therapy or therapeutic home exercise. It is one of the cornerstones to getting patients feeling better. Now, how do I determine what patient is a candidate for a therapeutic home exercise program versus a formal ambulatory course of physical therapy? First and foremost, patient autonomy. Patients have preferences. Patients are busy, and I respect that. I know what it's like to be a busy person. I would have a difficult time integrating a really robust physical therapy course, a formal course in my life. Now, that being said, it is necessary, I think, for some of our patients to still do formal physical therapy. So who goes with a therapeutic home exercise program? Let's give you an example. The patient who maybe has good range of motion, symptoms ongoing for 4 weeks, less severe cases, patients who are reliable, patients who are interested in getting better. Sometimes patients have problems and they're a bit apathetic about them. They show up, they want to be reassured that it's not anything too dangerous. And in those cases, sometimes patients just want the reassurance. They go on their way and they're good to go. So a therapeutic home exercise program, I find that they work better for the busier types, the types that don't have the bandwidth in their schedule to do formal physical therapy, and for the problems that are not as severe. So you could imagine if a patient has symptoms ongoing for 6 months, let's say the laborer who has to show up to work every day, put food on the table, they can't take much time away from work. Those are the cases that I think definitely benefit from formal physical therapy and the expertise of our physical therapy colleagues. If a patient has an excuse, and I know that they would benefit from formal PT, we could do FMLA. There's a lot of ways to work around it. Really what's key with PT or a therapeutic home exercise program is consistency. That is really, really what's most important. There is a lot of opportunity, I will say, in the therapeutic home exercise realm in terms of monitoring, in terms of compliance. That is a problem that is very tricky. Here's some inside baseball. So if a patient tells me, I can't do physical therapy, I can't swing it, financially, bandwidth, but they need to do their physical therapy to get their MRI. Some patients, they show up, they want their MRI, and they will do the work to get their MRI. One of the ways that we can circumnavigate that boundary is with a clinician-directed home exercise program. And as long as I see the patient, provide them that home exercise program, and then I see them in clinic 6 weeks later and they tell me that they did it, that will suffice the requirement from the insurance company's perspective to get the MRI authorized, usually. And I'm okay with that because I like to help my patients out, but at the same time, there's not a great method that's widely used to monitor compliance with a clinician-directed home exercise program. So do you all use a particular tool for that kind of thing by any chance? I know that there's Hep2Go and WebPT. And can you get feedback whether or not the patient actually did their exercise program?
Yeah, they have like little check boxes that they can do, and then they can even provide feedback to specific exercises as well too.
So here's the question though, because a lot of these things, how can a patient prove to a clinician or an insurance company, whatever the future may look like, they can click boxes or maybe provide feedback, but I'm curious to know, or even to explore further, how to optimize that problem, because 6 weeks is a long time. And if a patient is just going to let status quo continue for 6 weeks, they're missing out on the benefit of those exercises. We can talk offline about that. Let's get into interventional care. This is what I do a lot of. Porcho does even more than I do. Ultrasound-guided corticosteroid injections. So corticosteroid, most of us have heard of corticosteroid. It's a very potent anti-inflammatory. It's used in many systems of the body. It's used in eye drops, ear drops. It's taken by mouth. It's used as topical creams. And certainly we inject it. I don't really like to inject it. Why don't I like to inject it? It does have side effects, just like everything else in medicine. Now, I've never seen, I'm just gonna, in full transparency, I've never, ever seen a major issue with corticosteroid use. However, we'll talk about it, but PRP is safer, no doubt about it. So what are those risks? Anytime we put a needle through the skin, there's a risk of infection. Again, fortunately, knock on wood, haven't seen one, but I've had colleagues who have seen infections. The corticosteroid drug class can elevate blood pressures a little bit, particularly in patients who are predisposed. It can elevate blood glucoses, particularly in patients who are predisposed, diabetics. And it can have local side effects. So it can cause atrophic side effects, meaning it can weaken soft tissue a little bit. The terms that we use, tenotoxicity, so toxic to tendon, the tendon units. Chondrotoxic, it can be toxic to the cartilage when we inject it in joints. So the point here is we try to minimize use, but you could imagine the use case would be the plumber, the electrician, the athlete. They're miserable. They can't get through a PT program. We don't like to prescribe controlled substances for these types of issues that are treatable, especially if we can identify what the problem is. So there are some patients who will show up and they will want a corticosteroid shot because they're in so much discomfort and there's not really another great solution. So in the image, what you're going to see here, this is the humeral head, supraspinatus tendon, overlying deltoid. There's the needle. When we do our injections, they're all done with ultrasound guidance. I know Dr. Lloyd definitely did that. PRP, we're going to dig a bit further into PRP. PRP, it's safer. There's no atrophic side effects. There's no bumps in blood pressures or blood glucoses, and it works. Now, there's some other stuff out there, mesenchymal stem cell treatments. There's a lot of really fancy stuff out there. The evidence is developing. There's a robust set of data that supports PRP. It's not a slam dunk, but PRP is pretty well studied. So, orthobiologics. Orthobiologics, it is the field of using one's own tissue, blood, adipose, bone marrow, to get a certain outcome, usually pain relief or increased function. The formal term, it's autologous, meaning from oneself, biomolecular, so biologic molecules like proteins, interventions to restore pain and function. Now, PRP, certainly the most widely used. When we talk about stem cells, patients will hear a lot about stem cells. The term stem cells is kind of a hot topic in sports medicine. Truly, though, when patients think about stem cells, oftentimes the stem cell they're thinking about is a pluripotent stem cell, meaning a cell that can differentiate into skin or muscle or bone. That is not the state of the art of stem cell treatments in the United States. Truly what these stem cells are, at least the ones that are the most evidence-based, are mesenchymal, or sometimes referred to as medicinal stem cells or medicinal signaling cells. There's different acronyms, but MSCs. MSCs, they can be derived from adipose, the bone marrow. These procedures are done here in Seattle. Dr. Porcho does do some of it. I think he does bone marrow primarily. Why can't we do pluripotent stem cell treatments? FDA regulations for now. And Porcho in his talk had all of the legal terms and the federal regulations, but it's beyond the scope of this talk. Basically, for stem cell treatments or orthobiologics, we have to abide by minimal manipulation rules, meaning we can't culture tissue, put it in some kind of culture, modify the genetics, do some of that really fancy stuff that they can do in the academic world. So it's tricky. Now, use cases. What does PRP and orthobiologics, what is it useful for? Osteoarthritis, mild to moderate osteoarthritis-related pain and discomfort. So we have massive data sets for knee osteoarthritis. Now, you could imagine that the less severe the arthritis, arguably the better outcome, and that certainly is proven by the data. Now, we grade knee osteoarthritis, just to get into knee osteoarthritis, we do a ton of PRP for knee osteoarthritis. We grade knee osteoarthritis from 0 to 4, 0 being no osteoarthritis, 4 being what many will call bone on bone. 1s and 2s do very well with PRP. The 3s do pretty well, not as good as 1s and 2s. The 4s, my advice to patients is save your money, don't do PRP. The outcome probably won't be that great. That is the state of the art in regard to PRP in terms of osteoarthritis. However, I have had a patient who, despite my recommendation to avoid PRP, he was a rancher, bilateral, grade 4, glenohumeral joint arthritis, wanted to do PRP. We did it. He had pain relief at his 8-month follow-up. So the point there is that we don't quite understand all of the nuance when it comes to the orthobiologics. Why is that? When a patient takes a Tylenol, a blood pressure medication, they're getting a purified small molecule that has a well-understood impact on physiology. With injecting or concentrating platelets, my platelet count is different than Joey's platelet count. My hydration status will modify the platelet count. What my platelets release, it's different than what Sophie's platelets will release. So it's harder to homogenize the variables in the studies. Now, PRP, it's great for tendinopathy, bursopathy. This image, let me see if I can get this to play. And I think the cool thing about it is it kind of shows the resolution of how cool ultrasound is. And this is a decent ultrasound. And this was a patient who had a corticosteroid shot at an outside clinic and then suffered a rupture of their common extensor tendon, a tendon in the elbow. Just for reference, that's the radial head, and that's the distal humerus. Now, let's continue. So PRP, I know we're kind of getting towards time here. I'm almost done with the high points. PRP, this is the Arthrex Angel system. This is kind of your entry-level PRP system. This is the one that I use quite frequently in Everett. The ones that we use now with Dr. Porcho's practice, they're super fancy. Most garden variety PRP kits will use centrifugal force, whereas the really, really fancy ones, they'll use centrifugal force and flow cytometry. Flow cytometry is separating the cells in the blood using wavelengths of light. So it can separate the red cells from the platelets, from the white cells. So if anyone in the room is interested in PRP, and let's say you end up at a provider's office, you can ask them, hey, what's your kit look like? What's your system look like? Arthrex Angel, I would say, is probably state of the art. There's a lot of good systems, but Arthrex Angel, probably one of the better systems. Usually for a typical PRP injection, it's all done in one visit. It's usually scheduled for about an hour. The patient's blood is drawn with routine venipuncture technique. It's processed in one of these fancy centrifuges. The Arthrex ACP system, the one shown in that picture, takes about 5 minutes for the spin, whereas Arthrex Angel could be about 25 minutes. Then it's injected under ultrasound guidance. If you end up at a provider's office and they want to do PRP without image guidance, I would say politely request it. And if they don't have it, go to a place where they do offer it. PRP, it is pay out of pocket, so you really want the best outcome. Usually in terms of the symptomatic benefit, we often see symptoms improve at about 6 to 8 weeks. And it's not a binary shift in symptomatic improvement. It's a slow, steady improvement over that time frame. Usually we work with physical therapists. We get patients moving the shoulder, moving the tissue, mobilizing it. The key here is that PRP, it's really multifaceted in terms of how it works. It does involve cell proliferation. It does involve rebuilding the collagen matrix of the tissue that we inject. It modulates through biochemistry the inflammatory response, and it can help facilitate what we call angiogenesis, or regenerating these really small vessels to help the tissue heal. Now, I see it's 6:48 on my clock, so Pixel, this is my new practice, and basically a brief 1 or 2 minute blurb about it. I wish I could talk about this the entire time, but I know that you all showed up to learn about shoulder pain. Pixel, I worked in the healthcare system. I started medical college in 2010. It is increasingly evident that accessibility is challenging. It's increasingly evident that the outcomes in the United States are not up to par compared to other countries with similar economies. And there's, since COVID-19, increasing burnout among providers. It's been an issue. Now, Pixel is basically my practice that will leverage technology as much as possible to improve the quality of life, not only for patients, but for clinicians as well. In just very, very briefly, what is it? It's everyone's using language models. It's using language models, agentic flows. Does this resonate with anybody? Agentic flows? Language models, agentic flows to help coordinate patient care. So for Pixel, it's going to be a website, and we already have a beta version of the website. An LLM is basically like ChatGPT, or there's a lot of various options out there, Perplexity, you name it. The patient will go and type in their concern or complaint. The LLM will triage the complaint. First, it's going to identify who is it talking to, triage the complaint. Is an appointment required or not? If not, it can generate a therapeutic home exercise program, make recommendations about local PT clinics. If it is appropriate for the patient to get an appointment, the patient will be able to book the appointment on the website and be able to upload their chief complaint, history, physical, medication list, everything. So then when I actually see the patient in clinic, we're talking, we're engaging, and all of that silly baloney where patients are handed a privacy consent form, a consent form for this, fill this document out, it's all done. So it's really kind of changing how patients are going to get care. We're going to integrate all types of cool technology. I don't mean to brag, but it is kind of cool. We're working with Amazon, Google, NVIDIA, and Apple. So it's some pretty cool stuff. If you have an interest in this stuff, hit us up. This is where you'll find our newsletter. This is the website where you'll find the beta LLM that you can mess with. And my contact, this is Dr. Porcho's website and his contact. So that's all I got for you. I know I kind of went maybe 5 minutes over. Happy to address questions. Yes.
I don't have any problems yet,
Mm-hmm.
barring any anatomical hooks
Mhm.
or whatever you were describing.
Mhm.
What can you do to prevent rotator cuff? And I don't do like any aggressive sports, so just wondering how to not be like him.
So certainly some of us are predisposed to rotator cuff issues. If you don't have an issue with the rotator cuff right now, I would say continue doing what you're doing. There are certain snap judgments that we can make in medicine, and it sounds controversial, but it's true. We have to triage information very quickly in medicine. And I can tell that you showing up to this lecture with a supportive partner, your body habitus, keep doing what you're doing. The patients who get themselves into trouble, they often have layers of insults that contribute to issues, socioeconomic status, demographic variables, body habitus, labor stuff, poor nutrition. You're fortunate if you don't have any shoulder problems, just keep doing what you're doing. I would be careful if you are working out weighted overhead activities. Be careful with military press. Lat pull downs, usually pretty safe for the rotator cuff. military press, weighted overhead activities. The other recommendation I'd make is if the shoulder begins to talk with you, if you begin to develop symptoms, it's probably worth checking in with a physical therapist, getting an eval, or checking in with a sports doc or even your primary care provider and saying, hey, I'm worried about my shoulder. How can I get ahead of this? But keep doing what you're doing at the very minimum, and hopefully you won't ever have a shoulder problem. Other questions?
I actually have a lot of questions because it's very interesting, but I think probably a lot of them are beneath you, I think.
No,
My
yeah.
question is that you talked a significant time about shoulder impingement. Is that the primary cause you treat or you see in people?
Oh my goodness. I would say that as far as what I see in regard to the shoulder, I see it all. Operative pathologies that are not determined to be operative yet. So what I see a lot of are undifferentiated, painful complaints. So a patient shows up, hey, I've got shoulder pain for X amount of time. Shoulder impingement statistically is a large chunk of the patients that I see and the downstream consequences of it. But we'll see patients with shoulder pain related to what we call cervical radiculopathy. The physical therapists know what I'm talking about. Sometimes the shoulder can hurt and it seems like it's a shoulder problem, but it's primarily a nerve root that's being pinched in the neck. So when I see a patient, the chief complaint will be something like shoulder pain, but all of it's fair game. It's not uncommon where, here's a case. I had a 70-year-old male and he showed up, his shoulder was intensely painful for about 2 weeks. English was not his first language, and this was when I was practicing in Everett. So some challenges there with him even engaging with the healthcare system. He shows up with his daughter. We take a look with ultrasound. He's a relatively stoic guy, doesn't do laborious work. He manufactures jewelry. He had a full thickness rotator cuff tear. When I took a look with ultrasound, there was significant fluid in that subacromial subdeltoid bursa. I knew immediately something wasn't right. I walked him through what his options were. We ended up aspirating the shoulder because in that scenario, I mean, it could be infectious, it could be a malignancy, it could be so many things. So we can aspirate that fluid, send it to a lab for study. There was blood in the aspirate. So I knew that he probably had a tear of his rotator cuff. Ordered the stat MRI. He was visiting with Everett Bone and Joint Orthopedic Surgery within 1 or 2 weeks. So the point there is that we see all of it. Now, I see a ton of shoulder impingement, and I'm really comfortable with impingement and the ultrasound-guided procedures for impingement, but we see all of it.
Can it be a result of first some kind of accident like a trauma and then continued use of your shoulder causes that?
Great question. Yes, totally. To use an analogy, I'll see a patient who shows up to my practice and they'll say, my right knee has been hurting for 2 weeks. And let's say that down the line we get the MRI and mechanically things are okay. We get an x-ray and the x-ray shows grade 2 or 3 knee osteoarthritis. That didn't show up in 2 weeks. So how do you reconcile that? That process has been ongoing for a while, and then in many cases there's a sentinel event that triggers that inflammatory response and causes pain and dysfunction and all the symptoms that we talk about. So it's not uncommon that a patient shows up and they jostled their shoulder a bit. Let's say that they reached in the back seat to grab something and they felt a little bit of discomfort, but then it really evolved into something that was really hard to manage or deal with. We take a look with ultrasound and we see that they have moderate rotator cuff tendinosis, let's say involving that supraspinatus tendon. The joints look fine, the glenohumeral joint looks fine, the acromioclavicular joint looks fine. It's not radicular symptoms. So totally, yes, it's one of those concepts that is a bit tricky to understand. To push it even further, imaging findings don't often correlate with symptoms. That's kind of one of the sub points there. Patient shows up, they say, my left knee really hurts, my right knee, it kind of hurts. We get the x-rays of both sides. The right knee is a grade 4, the left knee is a grade 1. How do you reconcile that? So totally, yes. We'll see imaging findings that it's apparent that the patient has been working on that pathology for months, if not years, but it only became symptomatic in weeks or months prior to the visit. So What else? Come on. There's got to be something you guys can challenge me with.
Yeah, with like MRIs and stuff like that, like I feel like we've been trained as PTs to like, I feel like there's so much new evidence that they preach to us and saying, you know, like they're not like they're the gold standard for sure, and like instead of like pushing patients or trying, it's almost like we're trying to deter them away from that and change them out as long as there's not like big red flags to indicate like to go down that rabbit hole.
Yep.
Do you ever feel like you're in a situation where you're trying to like deter that as well? Like I feel like it's trying to educate and explain those things. It's a sensitive topic sometimes.
Totally.
That,
Yes.
pain isn't necessarily correlated to tissue damage. There's like all these the biopsychosocial model. And
totally.
All these things that kind of come together. So I don't know if you have a similar experience or.
100%. And, I can't blame my patients for wanting to see the gold standard imaging study. A patient gets on Google, they'll end up at Mayo Clinic, Cleveland Clinic, and it'll show somewhere on the bottom, hey, you may need an MRI. So patients will show up and they'll want to see that MRI. I have pondered this question for years, and it's tricky. And ultimately what I tell patients is, because every human is unique. Their temperament, their personality, how they experience pain and suffering and misery, it's all very unique. So I tell them directly, honestly up front that we can get an MRI, say that we have the stubborn type. They want that MRI and they're getting maybe a bit fiery about it. I tell them we can get it. It's really a matter of who's going to pay for it. And I've had some patients take me up on the offer of ordering it and them paying out of pocket. It's that important for them to want to see the MRI images that they'll pay for it. Most of the time, they'll say, hey, you were right. Very similar to you. In most cases, it is an issue that's going to resolve without surgery. There are these very complex variables that contribute to how a patient experiences their pain. But I'm direct and honest and upfront with patients. And I think there is a bit more awareness and transparency in regard to insurance companies dictating care in some cases. And that is, it's a bit reassuring to me that patients are beginning to understand that clinicians, our hands are tied in some cases. So I don't know if that addresses your question, but I don't try to push patients away from it. I tell them the facts and tell them, hey, if that's really your objective, we can accomplish your objective. It's going to be painful to your pocketbook.
Yeah, that's good.
Yeah. Other questions? Yeah, shoot, Sophie.
You might have mentioned this or gone over this and I missed it, but you mentioned that subacromial bursa can fill with fluid. Is that due to a tear or is there other causes for that?
So I'll tell you, Sophie, you can see fluid in the bursa even if there's a bit of tendinitis. Tendinitis implies by the name that the tendon is inflamed. That itis suffix implies that it's either inflamed or infected. We can pick up infection pretty easily. Is there a fever? Is the patient tachycardic? But tendinitis, that's inflammation. Inflammation, remember, when something's inflamed, there's going to be, in many cases, a bit of warmth, swelling, which is the edema, dysfunction. Those are some of the classic findings we see with inflammation, acute inflammation. Now, if there's a bit of tendinitis, you can see fluid in the bursa. If there's, tendinosis, the chronic form of tendinitis, you can see fluid in that bursa. If there's a tear, certainly you're going to see fluid in that bursa. So when I pick it up with ultrasound in real time and the patient is seeing what I'm seeing and I call out, hey, there's a bit of fluid in that bursa, the next part of the conversation is, well, why is it there? And it can be there across the entire spectrum of the pathology in impingement. So even if there's a bit of tendinitis, fluid in the bursa, we'll often pick it up. Full thickness, attritional, or even acute tears, we're going to see fluid in the bursa. So it's data. When we see fluid in the bursa, it's data that something locally is inflamed, and that's really what it's useful for. Yeah. Other questions?
Yeah, one more.
Shoot.
It's regarding the shots.
Yeah.
You'll have
Mhm.
shot versus the plasma one PSL.
PRP and CSI. Yep.
Thank you.
Mhm.
So you said that you try to steer away from the plasma one, and then
Corticosteroid.
corticosteroid.
Yeah.
Then because I find that to be very common. So when we go to any medical facilities, that's the first one they're offered, and I never heard about the plasma one. That was never an offering or an option. And I feel like it's kind of they push it on to especially athletics that like an Advil, like do you just want the shot, and then but it takes I think 6 months before you can get another one, and then I found that it it's essentially eats your cartilage,
Yes.
so that's a huge problem.
Yes,
So
you're right.
does insurance not cover the plasma? Is that why they should?
Yes, exactly. So again, talking about insurance companies and what they reimburse for and what they don't reimburse for, it's a problem in this field. And that is a whole topic of discussion, again, that I pondered with colleagues smarter than myself for years. I don't have a good answer for why insurance companies don't pay for it, because there are randomized clinical trials that prove that PRP is as efficacious, if not more efficacious, for many of these musculoskeletal conditions. You can put your tinfoil hat on, you can put whatever, but I think it's economics. The other component is if you have a small molecule that's developed in the world of pharmacy, that the group who's going to fund the R&D for these really large multi-site clinical trials are the pharmaceutical companies. We need pharmaceutical companies. They do amazing work. They develop a ton of amazing therapeutics. But what about PRP? They're not really in the PRP business. So how do you fund a PRP randomized clinical trial? It's usually a pioneering clinic with providers who offer this product and then study it internally and then publish their data in respectable journals. And that's exactly what happened with PRP. I don't know. I don't have a good answer. But what I would say is if you've been to other clinics and that's all they're offering, come visit me in Portugal or Swedish. They'll take care of you. Do you mind if I ask where you seek care? Is it a large system? Is it University of Washington or Swedish or?
Right now, I don't have any major injuries, but my number one is always I'm healthy, I'm very young, and I can heal myself very quickly. I know how to do basic research, and luckily my injuries were all things I can heal on my own. I'm very much against any foreign medicine type things because I was growing up back in Europe. The first thing in any kind of issue you had was always how can we treat it naturally. They always steered away from medicine because medicines have all sorts of side effects, and they don't want that. But I find that in the U.S. it's harder because they first thing they want to push is the medicine.
Yes.
So I want that to be the very last resort.
So really, one of the issues buried in what you're describing is what I'm trying to improve with starting this company. And that is, I wanted to move away from this idea of RVU productivity. So most clinicians, even those who work for a nonprofit like myself, when I was working for Providence, there's a lot of pressure to produce RVUs, relative value units. We don't have to get into the details, but if you just get on Google, look up RVUs, it's the reason why clinicians often have 15 minutes with a patient or 20 minutes. And even though I was building up a nice practice, I was getting pressure to produce more RVUs for the institution. It didn't really jive with my morals and my ethics, which is why I wanted to do something different. So you're exactly right. It's a problem. Other questions?
I'm more interested in your startup.
Yeah, man.
How long have you been doing that for? You're a co-founder?
Yeah, I don't have a formal co-founder yet. I've got people who are kind of with me at the early stages. But yeah, I'm in a transition and currently spinning up 2 companies, Pixels 1, and then a capital investment firm 2 to help drive this stuff. If you have interest, hit me up. I wake up every day at 4, go to bed at 10, around the clock. Yep. If you have an interest, let me know. Other questions? All right, very good. I really appreciate the opportunity to talk today. Thank you.